I'm Howard Feldman. I'm a neurologist. I direct a team called the Alzheimer Disease Cooperative Study, the so-called ADCS. We've been around since 1991. It is a great honor to be speaking to you today and to follow on Jim's enthusiasm of the progress that we're making. So imagine, this morning at 7 in the morning, I got up, went to have coffee. Even before having coffee, turned on my phone. There was a deluge of information about a treatment called donanemab. And donanemab made its phase 3 outcome measures successfully and looks like it will be destined for FDA approval. Now, this is the second amyloid-lowering treatment since January, potentially to be approved for the FDA. So I've been coming and talking to you, I've been privileged to talk to you year in, year out, always with the belief and hope that research will pay dividends in treatment progress. It's here. So we're going to talk about real treatments that are becoming available. Some of the caveats, as neurologists, we sometimes deal with treatments that have both benefits and risks, and these are no exceptions. And you will be learning about some of the risks inherent in these new treatments. It's going to make a complex therapeutic discussion. Is this the right treatment? Is it not the right treatment? But it's very exciting to at least be having treatments to talk about. So with that as our starting point, I've named this talk at long last, The Dawn of the Era of Amyloid-Lowering Treatments for Alzheimer's Disease and Beyond. Here's some disclosures. So this is, when we do our work, we end up interacting with a lot of different people. I did want to mention that in 2013, so a decade ago, I spoke to Biogen at the time that they were just beginning their aducanumab program. They weren't so keen on what I had to say. That was the last time I spoke to them. I was involved with Eisai Pharmaceuticals, who manufacture lecanemab, in 2018. But really nothing that represents a significant conflict. And then, as you can see, we work with all kinds of partners to develop new treatments. So I can't. I can even shout. So we will accomplish 3 things during the next 20 minutes or so. I'm going to give you examples of how targeting amyloid and tau pathology results in treatment progress. So Willie Sutton was asked, why do you go to the bank to rob the bank? And the answer was, that's where the money is. So looking down the microscope, the money is on plaques and tangles. It's the obvious place to look, and it is the place that the last 40 years have been spent looking. I want to make sure that you leave this morning with a good understanding of the amyloid treatment. Particularly, we'll look at lecanemab because I think it's the first one to become available and the one that we've seen the most data on. But last week, as if for good measure, it wasn't enough that we were going to see donanemab, but there was this wonderful report that came up about an antisense oligonucleotide for tau. And what's really exciting about that, it was developed just up the road by Ionis Pharmaceuticals, so in Carlsbad. And I want to share with you some of my excitement about that, because it's such an imaginative idea that they had, and it seems to be working. And then closer to home, you should all be aware of the things that we're doing at the ADCS. So if you wish to volunteer in a therapeutic trial, we have colleagues around that will receive your interest and be able to provide you direction and how you can participate. So this is pretty important as a simplified framework, a way to think about what treatment might do. So we know that if you've got Alzheimer's disease and it's not treated, we know that there's a downward, inexorable progression. Some people faster, some people slower, but virtually by definition, the disease gets worse as we follow you over time. We've had the privilege of using the red drugs symptomatic drugs, donepezil, rivastigmine, memantine, since the late 1990s. They help some people symptomatically, and they help for some period of time. They don't change the underlying biology of the disease. So they help perhaps a third of people. There are various, we've learned a lot about what that help looks like, but they don't modify the disease. This morning we're starting to talk about disease-modifying drugs. So drugs against amyloid that actually change the pathology. If you can imagine it, it turns a lot of amyloid in the brain into not measurable amyloid in the brain. So it's really effective at removing amyloid from the brain. And we're beginning to learn about this blue curve called disease modification and slowed progression. So we now have the opportunity to look at that. And just to fast forward, and so you can begin to anticipate what's coming, imagine for a moment that we could reduce by 25 to 35% the slope of decline over time. That is about the range that we're accomplishing with these monoclonal antibodies. So we're reducing the decline by 25 to 35%. It is not going to translate necessarily into visible symptomatic benefits because persons are still declining. But the pathology of the disease is being removed from the brain, and there is some attenuation in the rate of progression. So this is a very important concept, because underneath appreciating this treatment will be the idea that it may not help symptoms, but it's going to attenuate on average by 25 to 35%. That is important because it then takes us with the hope towards the black line, which is if we can achieve 25 to 35% with amyloid lowering treatment, maybe we can add a tau treatment, gain another 25%. Maybe we can add another something or else or other, get another 25%, and maybe with a combination of treatments we will get to our hope, which is the black line, where we actually get to stop the disease and arrest it, which was the hope when I started in this field in 1980, the hope that we would actually get to that point. Now this is a very long trajectory, so year on year on year we come and talk to you about the pathway to development, and look at where you have to get get FDA approval. You have to run through basic science discovery, drug discovery, preclinical testing, phase 1 trials, phase 2 trials, phase 3 trials, FDA review, then approval, then someone has to agree to pay for the medicine. And that's not an inconsiderable task, and I'm going to say something about that this morning, because payer decisions are important. These monoclonal antibodies so far have ranged from $25,000 to $50,000 per annum for treatment. So if someone says they'll pay, it's going to make a huge difference. If someone says they're not going to pay, it's going to make a huge difference. Either way, those are critical path decisions that are still to be taken. So this is where we've gotten to with favorable FDA reviews. This is where we're anxiously attending with you to see what Centers for Medicare decide about how they're going to pay. So these are these beautiful images that we get to see under the microscope, and when Jim talked about brain donations, and when we have the opportunity to look at the brain, we're looking for these kinds of plaque, amyloid plaques. So this is made up of dense core amyloid. There's a core in the center, and then this is a neurofibrillary tangle. This is made of tau protein, and tangles would represent the degeneration of a neuron or nerve cell. So normally nerve cells sit like pyramids, so if you can imagine a pyramid, and when it loses its internal structures, it collapses in of itself, and it becomes a tangle, and it becomes really a shadow of its former self. So tangles and plaques. I should say, just imagine this for a moment. Dr. George Glenner, in 1984, was working in a lab on the UCSD campus. I think he was a basic biochemist, and he stumbled into this protein amyloid, And he described it in a paper. I recently pulled it out. It looks like he wrote it on a typewriter before the days of a computer. But he described the protein beautifully, and he imagined that removing amyloid would one day become a treatment. That was 1984. It now takes 40 years of development to get from there to a treatment that we can actually provide to you. And you are really the bearers of the opportunities that we have in research to get there. There's been a lot that we've learned about amyloid. We have learned that it's a long parent protein called a precursor protein. It gets snipped in various places by secretase enzymes, and it forms into various size amyloid plaques. It looks something like this. We get very small fragments of amyloid. Those grow. They seem to have they're very, very sticky. They like to attract their friends. They grow into these things called oligomers. Oligomers seem to be very pro-inflammatory. If you have oligomers in the brain, the inflammatory cascade lights up, and then you get both effects of inflammation that are protective but also injurious, and eventually they form into diffuse plaques and compact plaques. Now, what remarkable things. Jim talked about the biomarkers that we do. We use all of them to develop these treatments. So we've looked at the pathology. This is a PET scan. The warm colors represent the buildup of amyloid in the brain. So the red represents abnormal collections of amyloid, and this is the target of the amyloid antibodies, which is to rid the brain of those amyloid proteins that have deposited. We similarly measure the amyloid proteins in spinal fluid, and excitingly, and how great will it be when we really master the blood test that can be used to give us the same information as spinal fluid. Now, these are the two monoclonal antibodies, and I mention this not to go into detail, but only to indicate that they're different. So they have a different genesis. One of them developed off of a mutation in an Arctic mutation family in Sweden. Another came out of studying older persons for their antibodies, and then they were mass produced into aducanumab. What a clever idea to take healthy agers, look for antibodies, mass produce them, and then infuse them back in against amyloid. I thought that was a very interesting idea. Donanemab has a different target. So donanemab does not equal lecanemab, does not equal aducanumab. They're all a little bit different. We don't yet know enough to know how they're going to differentiate from each other in the clinic. So as we begin to gain wide use of those, but they are different, and so they will have different side effect profiles. They will look a little bit different when we look at how effective they are, and decisions will need to be made by clinicians around which is the right one, the right treatment for the right patient. That's going to be the task at hand. Along the way, there's been a lot that haven't worked. So this is really just a sampling of 3. We could put up probably 5 to 10 that didn't work to get to the ones that worked, and we learned a lot. We could go into it in more detail, but it will be a little tangential to the talk today. So this is the notice that we got that the FDA had approved. Lecanemab, as mentioned, in January of this year. Aducanumab was approved in June of 2021. Aducanumab was a very controversial approval. It, as the first in its class, and also with a lot of discussions around the regulatory review of that compound, with one study being positive, one being negative. It generated a lot of uncertainty. There was a large fallout from it, but I think that really got superseded by lecanemab, which was strongly positive on all its outcome measures and really removed doubt that this actually works. And that was reflected through the press, and I'm sure you've all been reading about it. It achieved an accelerated approval. Probably the details of accelerated approval are not so important, only to say they don't yet have full approval. Lecanemab will be up for full review in June or July, and it may receive full approval. And you may realize from the COVID vaccines, they get conditional approval and then eventually they get full approval. It's going through that process. When the FDA feels that it's important enough that people should start receiving it, they approve it conditionally through this accelerated approval mechanism. The other thing that the FDA leaned heavily on in approving this was the unambiguous evidence that it removed amyloid from the brain. And they accepted that if you removed amyloid, you would end up helping people in their everyday life and in their cognition. So they bet on that relationship without certainty that it would be there. But lecanemab eventually, and now donanemab, tell us that was a good bet. Now the interesting little sidebar of this is that the person at the FDA who spearheaded this left the agency under a huge cloud and a lot of controversy. But in some ways we owe him a gratitude, because I think he felt that he knew what was coming and that it was going to work, and he wanted to put a stake in the ground to help everybody move faster. Anyway, so bit of opinion there, but something to consider. Okay, so now we have medicines. Now the question is, who are they going to work, who are they approved for? How effective are they? What kind of expectations can you have about a treatment? How do we receive these treatments? How often? How long? What are the risks? What are the costs? Who's going to pay? And so on. A lot of questions. And we're going to kind of go through this fairly quickly, but we're going to touch on all of these points, albeit fairly quickly. So this is what the 25% looks like. And really, I want you just to take away the artistic impression here. And there are two curves. There is a curve for lecanemab, which is the gold color, and there's a curve for placebo, which is the blue color. And you can imagine that the separation in every instance for the gold color lecanemab is better than placebo. But you can see that they're both declining. So the slope is downwards. But you see, for example, on this first measure of everyday community functioning, 27% slowing at 18 months. For cognition, 26% slowing at 18 months. For everyday function, 37% slowing at 18 months. And this is the difference of amyloid removal. This is almost a 60% reduction of amyloid. So you can begin to get a feel for what this looks like. Now, equally important, or perhaps something that captured my imagination even more, was what about quality of life? What would a person who's receiving the treatment base their evaluate, like, how is my quality of life on this treatment? And actually, this looked even more interesting. 49% better with lecanemab than with placebo in self-reported quality of life. So even though we don't imagine that you could tell the difference, people seem to be reporting less decline. And in the opinion of informants that went along with the affected person, 38% less decline. So I think both of those are important to me and probably important to you as you consider decision making about this. Now, what's the price? What's the risk? Potent therapy, infusion reactions, so these may be allergic type reactions. Almost 1 in 4 people have that kind of reaction, generally easily dealt with antihistamines, with other medicines to damp down an allergic reaction. The interesting thing is that they often go away after the first administration, but when you go for an infusion, there has to be someone around in the event that you have this type of an infusion reaction. Now there's this other thing called amyloid-related imaging, and this is important because I'm going to show you some images here. This is a relative, don't look at that white spot, but this is a relatively healthy side of the brain, and you see that related to the disease there's some widening of the fissures in the brain, indicating that there's been some brain loss. If you look on this side, something different is happening. there's a lot of high signal, what we call high signal, and the brain no longer has its normal fissures. It actually looks quite swollen. And actually this is called amyloid-related imaging abnormality, edema, E-type. And so this occurs in 12.6% of persons treated. So a 1 in 6 chance that you would get this. Importantly, 3% or so are symptomatic with it. And symptomatic might be confusion, nausea, vomiting, and in extreme situations it can lead to coma. And rarely one has to allow that it could lead to death. So very rare. You'd have to be extremely, extremely unlucky, but 3% will be what the doctors are going to be telling you, the risk of symptomatic. This will go away. Often, if you stop treatment, it will just go away over time, and treatment can be restarted at a later date. The second thing is area H, which is hemorrhage in the brain, and symptomatic hemorrhage in 0.7%. Now, hemorrhage has risk factors attached to it. There was a lot of news about someone who had died from a hemorrhage in the brain while they were taking lecanemab. It turned out it was a little bit more complicated. They had had a stroke. They got put on a very powerful blood thinner to clot bust the stroke. Then they had a big hemorrhage, and unfortunately they passed. But it was a very complicated situation, and it will be dealt with by caution about risk factors for hemorrhage to begin with. So there will be a need for MRIs to look for hemorrhage and to follow for hemorrhage. So this is from the prescribing information. It's for persons with early Alzheimer's disease, and it's quite narrow because it's following the research that was done. So you're going to ask, well, what about moderate disease? What about severe disease? What about persons that don't yet have symptoms? Can it be used? We just don't know yet, and it's not approved for that use. What is the drill? So it's going to be required that there be shown to be amyloid in the brain. There's no point having an amyloid lowering treatment. You don't have amyloid in the brain. So it's going to require a biomarker, either spinal fluid or imaging, amyloid PET scan, or maybe blood. We're not sure yet. It takes an intravenous infusion every 2 weeks. It will take MRI follow-up to look for area, and that's going to be what's involved in this. Who's going to pay for it? We don't know yet. The company has said $26,500 for the treatment. Jim and I have been talking about the additional cost because there's going to be a lot of MRI, there's going to be a lot of clinical follow-up. It may be double that. But I think that CMS, personal opinion, I think they're going to pay for it. Whether there will be any conditions on the payment, I don't know yet. Donanemab. Time will not allow us to go into detail of it, but here's what the phase 2 data looked like. Based on the press release this morning, phase 3 looks similar, and what I can say is the effect sizes look entirely consistent with lecanemab. So here we have another antibody, different antibody with effect sizes that look at least similar, same ballpark. So we're very excited. This was my future-facing slide. Thankfully, the future is today. I think time is probably not going to allow too much discussion, but just to say a word about these antisense oligonucleotides. So imagine for a moment if there's a protein that gets produced in the brain where DNA provides instruction to RNA to produce a protein. And imagine for a moment that you could insert a spanner in the works between DNA and RNA, and where you could stop the RNA from producing the protein. That's what this treatment does. And so with this experiment using a tau antisense oligonucleotide, the production of tau was reduced over a period of 1 year by 50%. So being able to reduce tau using an antisense oligonucleotide to just shut it down. And the amazing part was this was the safety and tolerability report. Really, it looked like nothing serious was coming out of the use. This is administered through a lumbar puncture. It's only in phase 2, so it's a bit of time away, but I have to tell you, this was breathtaking in its significance. These are 3 trials that we're working on here at UCSD. If anyone is interested, by the colorful names VivaMind, varoglutamstat, and I just want to say one thing about it. It's a small molecule equivalent of donanemab. So it looks very much like donanemab, but without infusions, by pill form that you could take every day. We have benfotiamine, or the trial name benfotiine, and we have modified AD. I'd be happy to answer any questions about those treatments. So in closing, to just mention that we had a very generous philanthropic donation from Dan and Phyllis Epstein in the amount of $50 million. Dan and Phyllis said, Howard, we need to do better with treatment. What are you going to do to accelerate treatment? And we came up with some very imaginative programs of research, one on gene therapy led by my colleague Judy Paw, which will be looking at families in Southern California and Mexico with a particular form of the mutation of presenilin, with the hopes that we can build a gene therapy specific for those families. One of them is called Powder for Pennies. The goal is, if we can achieve something with a monoclonal antibody for $25,000, maybe we can do something with a much cheaper form of treatment. No company is going to be looking for that. Why not us do it? So that's our Powder for Pennies, and you see some of the work we've done with bumetanide, a diuretic. So here are the conclusions. The era of amyloid treatment has arrived. Lecanemab, I've described for you the benefits. I've described for you the risks. I've described for you the costs. We had future facing a few days ago, donanemab, it's now the present, and we have tau therapeutics on the horizon. So our sincere gratitude to all of you. We couldn't do this without you, or our collaborators, or our grant funders. Thank you.